I'm John Geaver for MedPage Today at the American College of Gastroenterology meeting in Orlando. The college has been working on a top-to-bottom revision of its guidelines on management of irritable bowel syndrome, or IBS, first issued in 2002. Several members of the panel developing the guidelines gave previews here of the revision, which is scheduled for final release this January. The guidelines now address the evidence for treatment approaches such as lubiprostone, rifaximin, and perhaps the hottest of all, at least with patients, probiotics.
Probiotics, all my patients are interested in probiotics. Every patient I see now asks me about it. I don't know about the rest of you guys, but it's really interesting how the change has occurred. And they also ask what type and how often and et cetera, et cetera. So the data are, the guideline will basically say that probiotics are efficacious, but the evidence supporting this is not as good as we would like. That's how I see the wording. That's how the wording should be interpreted.
Antidepressants, including tricyclics and serotonin reuptake inhibitors, also have a place in the new guidelines for reasons that may surprise some people.
SSRIs, these are a newer class of antidepressants. They tend to have a little bit less in the way of side effects. And in IBS, there are now data available, and the data were pooled, and looking at that, this class of drugs appears efficacious, appears to be better than placebo in IBS. Just like for tricyclics, it's a similar level of recommendation. Remember, the tricyclics are the low dose, the SSRIs are the full antidepressant dose. We are not treating depression. Okay? This does not appear to be related to depression. This appears to be related to effects of these drugs, either in the brain or the gut, but probably both places. And that's very key. And I want to emphasize the fact that this is not antidepressants for depression in IBS. This is antidepressant drug classes for IBS, whether or not they've got any symptoms of depression. It doesn't seem to be relevant to response.
The new guidelines also review treatments that the evidence shows don't work so well.
My experience interacting with, talking with gastroenterologists across the country is that first things they use for IBS patients are fiber and antispasmodic agents. And those are two of the things for which there is the least amount of good evidence to support their use. In my opinion, that the evidence for fiber in particular is that as we increase the dose, we actually make the patients worse because we worsen their bloating.
Another important area is diagnostic testing. Many clinicians may be surprised at the panel's conclusions.
The overriding issue with regard to diagnosis is that doctors are uncomfortable with assigning a diagnosis of IBS. They're worried that they're missing something else. So there are concerns with regard to missing colon cancer or ulcerative colitis, Crohn's disease. And the reassuring bit of information that comes out of our analysis as part of the guideline is that the likelihood of a person who has IBS symptoms and no warning signs, which are things like weight loss, GI bleeding, family history of colon cancer, inflammatory bowel disease, or celiac disease, is no greater amongst individuals with IBS than the general population.
Big issue in the guideline is saying, out in practice, a patient presents with abdominal pain and altered bowel habits, who's 20, 30, 40 years old. They get a ton of different diagnostic tests at a huge expense and some risk to the patient. And what our guideline is saying is that actually, if they don't have blood in their stool, if they don't have weight loss, another danger sign, you don't need to do that, because when they present with those symptoms, you can say they've got IBS, and if you do all those diagnostic tests, the overwhelming likelihood is, after you do them all, you'll still be saying they've got IBS.
But certain tests do make sense for many patients, Dr. Chey added.
Of the different tests that are available, I think one of the things that's new in the guideline is that we made a much stronger recommendation for testing for celiac disease in patients with diarrhea predominant or mixed IBS. So we actually came out and said that serological screening for celiac disease should be pursued in patients with diarrhea or mixed IBS. Diarrhea predominant or mixed IBS.
Finally, the new guidelines include a grading system to let clinicians know the strength of the evidence underlying them, whether the benefits greatly outweigh risks or not, Also, whether the research includes high-quality randomized trials or is based on case series and retrospective analyses. I'm John Geaver, MedPage Today.